Good evening. I'd like to welcome you to today's joint ESTS-STS webinar on the topic of robotic segmentectomies. Actually, Isabel Oppitz is scheduled to chair this webinar, and she's currently in the stage of logging on and will join us any minute. But to be on time, I will start with the introduction of our two excellent and profile speakers in this topic. So it's a great pleasure to welcome from the ESTS side Dr. Ilyas Bouabdallah from Hôpital Saint-Joseph in Marseille, and Dr. David Rice from the MD Anderson Cancer Center, University of Texas. It's a great pleasure to welcome both of you, and we're really looking forward to your presentations.
Thank you, Clemens. May I share my screen?
Yes, please.
Okay. Can you see my screen, please?
It's working perfectly.
Yes?
Fine. Yes.
Okay. Good evening, everyone, or good morning, depending where you are. It's a great privilege to be here with David for this excellent webinar about a very hot topic today. So we would like to thank the ESTS and the STS because it's a wonderful opportunity for us to choose you our field about and our thoughts about this topic. So we will do a duo presentation. David and I will talk each other, and we can interrupt ourselves. It's not a very formal format, and we will try to do the most fluid as possible. Here is our disclosure, and we're going to start with this kind of small lesion. Today, there is a lot of screening program, and we will face more and more this kind of very small lesions. So today in 2023, what we have to do, thanks to the literature, it's not very obvious, and we want to try to develop the concept of personalized surgery. The current literature is, I'm sure you're very well aware about these two big randomized control, and we thought, David and I, to have a quick view on these two randomized control trial, because now we have a lot of answer, but still a lot of question. The first one is from our Japanese colleague. Is a very well designed and beautiful trial published last year. They compare lobe and segments, so no dot wedge, only segment and lobectomy in 70 institutions with more than 1,000 patients. And just to have a quick view about their population, it's almost the half of the population without smoking history. So it's not the same here in Europe or in US, so we have to keep in mind. And also, they have half of the population with mixed GGO, so half solid nodule and half mixed GGO. It's a lot of adenocarcinoma, more than 90%. And the main objective was the overall survival. And as you see, lobectomy is 91% and segmentectomy is even better, 94%. Why? Because we think in both arms, they cure a very localized disease. But with the segmentectomy, we have the feeling that it's like a protective factor because our patient will face probably other comorbidity, some cardiovascular disease, some other cancer. And just for the second lung cancer, we know that every year we have 2% of risk to have a new and a second lung cancer. So if you follow your patient during 10 years, you will have at the end 20% of risk to have a second lung cancer. And when you do a lobectomy the first time for the first one, it's difficult to offer a second surgery 10 years later. So it's a good message from the GCOG. It's also to see that on the segmentectomy group, almost 90% of patients can have an additional resection for a second lung cancer, whereas only 60% on the lobectomy group. Now we will face a major issue with segmentectomy is clearly the local recurrence. And we're going to try with David to answer that question and to try to decrease this rate. So to finish with the GCOG, I have some concern because we don't have a subgroup analysis between mixed GGO and solid nodule. We don't have very precise details about the distance. It can be an answer why they have such a difference between lobe and segment about the local recurrence, and not always frozen section. David, please, can you continue?
Yeah, thank you, Elias. So the second randomized study, as you're well aware of, was published earlier this summer, CalGB 140503. And this was a prospective randomized trial for small 2 centimeter size less small peripheral lung cancers, and randomized to intraoperatively to either lobectomy or sublobar resection. Now, the sublobar group in this case, and unlike JCOG, included wedge resection. In fact, 59% of patients had wedge resection, only 38% of patients had anatomic segmentectomy. There was a 3% conversion rate from sublobar resection to lobectomy. And importantly, this trial, not like JCOG, this trial required that patients undergo lymph node sampling intraoperatively to confirm that these patients were N0 status. And then for right-sided tumors, frozen section analysis was from the 4 and the 7 and the 10R nodes. For left-sided tumors, 5 or 6, and then the subcarinal and station 10 Ls. Additional important distinctions, as Ilya already pointed out, between this study and the JCOG study was that there was a much higher percentage of patients who were either current or former smokers, 91%, and a much higher incidence of non-adenocarcinoma. So the incidence of adenocarcinoma in this study was only 64%. But at a median follow-up of 7 years, which is the same as JCOG, sublobar resection was found not to be inferior to lobectomy in terms of disease-free survival, which was the primary endpoint. And in addition, there was no difference in overall survival either, which is 64%, which is a lot lower than the Japanese study, likely because the higher incidence, I think, of non-adenocarcinoma histology. And another difference between this study and the JCOG study was that the rate of lobar recurrence of local recurrence following sublobar resection was about the same as lobar, as the group that had lobectomy. So we didn't see that difference in local regional recurrence. There was a recent post hoc analysis of this study that attempted to answer the question of, does it make a difference whether or not you undergo segmentectomy or wedge resection? And so they analyzed the outcomes for disease-free survival, overall survival, and lung cancer-specific survival. And amongst these 3 groups, there was no difference. So it didn't seem to, certainly didn't appear to be a survival benefit for segmentectomy versus wedge resection. But there were some subtle differences if you look at the quality of quality metrics, say, for surgical resection, in that we see in the segmentectomy group that more patients seem to undergo a more complete lymph node dissection. The percentage of patients who were found to have positive nodes was slightly higher. The median number of nodes sampled was a little bit higher as well. And lastly, in terms of surgical margin, both had good surgical margins, but patients who underwent segmentectomy had a slightly larger median surgical margin. So that sort of finishes the randomized 2 important randomized studies that we have.
Yes, David, you're right. It's important to explain with some feedback these 2 big randomized control. And now we will talk only about intentional segmentectomy, so people with small lesion and able to have either a lobectomy or a segmentectomy. And it's clearly a difficult choice, and we will explain how to ensure good oncological criteria even for a segmentectomy. So we will try to develop all of this. First, we need to remember that the main issue for segmentectomy is local recurrence, and we will try to decrease this rate. For intentional segmentectomy, we do only for benign lesion or metastasis if a wedge is not possible. We can go also for a segment for pure GGO or a ratio less than 50%, and we can do a segmentectomy for a lesion up to 3 centimeters, thanks to the last paper from our Japanese colleague. Another one, GCOG 1211, an excellent work also for our colleague. But for the solid nodule and for the mixed GGO more than 50% of ratio, we just developed these two big randomized control. And I would like to have a small remark. I think it's good for small lesion, but we should avoid for too peripheral lesion. If you have a pleural invasion, you will have a PT2A and not a PT1A or PT1B. This is an explanation of the possibility to have some subpleural drainage and the risk, of some tumor cells on the remaining segment in case of segmentectomy. So when the lesion is too close from the visceral pleura, I think we should probably perform a lobectomy, and it's not on the guideline, it's just some doubt and some issue. And I think if we have doubt should benefit to the patient, because when we don't know, lobectomy is clearly a good weapon. So our colleague from Marseille worked about the distance from the visceral pleura, and you can see here, when you have a very small distance from the visceral pleura, you have a very high rate of local recurrence, whereas when you have more than 5 millimeters, the rate is very low. So now we will continue the webinar thanks to the recent European guideline in order to give you our feeling about this guideline and how to interpret all of this. So the first one is that segmentectomy is clearly an anatomic lung resection, meaning it's like a lobe. You have a bronchus, an artery, and a vein. It's just smaller. And it's important to remember that. And I love this very honest and beautiful paper from our colleague in Boston, saying sometimes segmentectomy is not a segmentectomy, it's just a wedgectomy, meaning if you don't have the bronchovascular element on your specimen, it's not a segment, and it's not easy to have it. So we will try to give you some advice to respect this concept. And they did a beautiful work, and they find nearly 20% of segmentectomy without a bronchus and a vascular element, not vein and artery, just vein or artery in this paper, and almost 20%. So the guideline number 2, it's about the classification, and they discourage the name of simple or complex, because I think it's not the most interesting aspect about the segmentectomy. So you can find on the literature typical, atypical, simple, complex, and it's not very interesting for the surgery. Much more interesting is about the lung function of the patient. If you do a segmentectomy and your patient are able to have a lobectomy, it's an intentional segmentectomy. When you can't offer a lobectomy because the respiratory function is too bad, it's like an alternative treatment. It's like a wedge or like stereotaxic. So we should to mention on the surgery title if it's intentional or not. Like this, when we do retrospective study, we can exclude, and we can exclude the compromised segmentectomy and just focus on the intentional segmentectomy if we want to compare with the lobectomy. And in the same idea, we would like to detail inside the surgery title the number of segments removed. On the left part of my screen, you have a right S8. It's only one segment. Then a basal segmentectomy is still a segmentectomy, but it's 4 segments. A three-segmentectomy is 3 segments, and a middle lobectomy only 2. So when we want to compare lobe and segment, we need to detail more about the title of the surgery like this. During a retrospective study, it will be much more easier to compare. David, please, about the functional benefits.
Yeah, and I think that that classification determining the number of segments is really important. So, on the face of it, it would seem to make sense. We've got good data to support that the more lung is removed, the greater the effect in terms of postoperative lung function is going to be. These are data from quite old now, from Harada and colleagues. And this decline in pulmonary function sort of seems to be worse immediately in the perioperative period. There's a little bit of return to better function at around 6 months, but consistently all studies have shown that patients who undergone segmental resection have less reduction of their pulmonary performance than patients who undergo lobectomy. Now, interestingly, at both the CALGB study and the JCOG studies, where they measured FEV1 at prior to surgery and then at 6 months, the differences in pulmonary function were actually smaller than anticipated. And in both cases, there was only an absolute difference of about 3% between the reduction seen after lobectomy and the reduction seen following segmentectomy. So a lot of work from this has been performed by Hiroki Nomori from Japan, and he's developed a technique using SPECT-CT imaging, perfusion CT scans, and recently published a retrospective study where they looked at over 300 patients who'd undergone either lobectomy and segmentectomy. And then they were able to measure the postoperative function at about 6 months using this SPECT-CT imaging. And what was really interesting about this was that they found that in patients who underwent less than 2 segments resected, these patients had a significantly improved postoperative pulmonary function compared to those who'd undergone a lobectomy. Whereas if you had resection of greater than 2 segments, that there really wasn't a significant difference between those patients and those who'd undergone lobar resection. And they were able to further break this down really at a subsegmental basis. And it turns out that 5 is sort of the break point. If you're resecting 5 subsegments or greater, there really is no functional benefit, these authors found, compared to just taking the whole lobe. And this is important because traditionally, a lot of the segmentectomies that we do, such as the upper lobe division, left upper lobe lobectomy, right, the trisegmentectomy, or basilar segmentectomy, where we're taking segments 7 through 10 on the right, that's taking out a lot of subsegments, and there probably is not functional gain in doing that. So I think this is a very important aspect when considering patient suitability for segmental resection. Yes.
Yeah, I agree. They said for the guideline 5 that the preoperative 3D planning is highly recommendable. And I think it's probably the most important part of this talk. The 3D planning is a new game changer. If I want to go from Marseille to Paris, I don't really know the road. I just follow my GPS, and the same for a new surgery I never perform. So sometimes you discover a new S3+4, even if you never perform this one. If you have a 3D planning, you have a great help. So you just cut the right, the blue and the red vessels. So it's much more easier with 3D planning and color than just on the 2-dimension black and white CT scan. It's clearly safe because you have no surprise in the OR. You have no surprise, you will, no bad surprise. And when your surgeon is much more calm and quiet, it's good for all the team in the operative room. So also you can be much more reproducible and always ensure good quality of your surgery. And you can decrease the time in the OR. So here is an example of one software. So there is several software available. This one is from Fuji, and I'm going to show you how it works. So we connect the packs, and we check for a CT scan with IV. Here we have a very small lesion inside the right upper lobe. It's a carcinoid lesion, 5 millimeters on the F3. So we explain where is the lesion. Then we check for the bronchus first, and after that we do the vascular reconstruction. You have on the red the artery, and in blue the vein. Then we're going to split the right upper lobe with the 3 segments. First, we check for anatomical variation. You can see there is 2 arteries for the segment 3 because we are dealing with the S3. So here is B1. Here, the next one is B2 now, and now B3. So I explained to the software where is the different bronchus, and now you have the reconstruction. I ask for 2 centimeters of lateral margin, and when you ask the lateral margin, you will see it's still inside the segment F3. So F3 seems to be a good surgery with good lateral margin for this small lesion, less than 2 centimeters, and not too peripheral, as you remember. Okay. Even if you have a 3D model, it's important, if you need it, to have an intraoperative localization of the target lesion, because we are dealing with small lesion, sometimes GGO, so you will face some issue to fill it. So you can also ask your colleague, some radiologist or some interventional pneumologist, to have a coil or a colorant. Or you can also try to use a concept of localization within the pulmonary segment. Like this, you have a plane, you plane your surgery before, and you stick to the plane. This surgery should be performed clearly by VATS or RATS, and I think even more important, it's ERAS protocol. Like this, you can decrease the length of stay, but also decrease the psychological and the physical aspect of the surgery. So anatomical landmarks are important for the 3D planning, and even with 3D planning, it's important to have a very distal dissection of the bronchovascular element. And it's not because you have a 3D planning that it's always 100% true, meaning sometimes you can have some mistake, and only what you see during the surgery is the real truth. Sometimes the software can have some mistakes, so you need to keep in mind that the surgery you will face some lymph node, some difficult fissure, some fibrosis, and all of this are not on the 3D planning. So 3D planning is a good help, but it's not perfect. So it's the same surgery. You remember this small lesion on the F3, you check for 2 centimeters, it's okay. Now let's see, there is a vein V3 and 2 arterial branches and 1 bronchus, 1 B3, 2 A3, one from the trunk of the mediastinal artery. So we start the surgery always with radical lymph node dissection. Here is station 8 and 9. Then now we are on the posterior mediastinal part with station 7. We always use roll gauze, this kind of cigar, to expose the field. We try to avoid grasping the lung. Like this, we decrease the risk of air leakage. Even the lymph node, we try to avoid to touch the lymph node, and we use this gauze. The radical dissection, you should be able to see the contralateral main bronchus. Like this, you have en bloc dissection of station 7. Then still from the back, you continue station 10 and 11 here on the bronchus. Here is station 10 from the front. We are below the azygos cross, so station 10. And after this lymph node dissection, we continue with the first element is the vein, V3. So here is another lymph node, station 10, and we dissect the superior pulmonary vein in order to identify V3. You can cut it, you can clip it, you can suture it as you like. And once you finish to identify V3, I think the secret for a segment S3 is to open the fissure between the right upper lobe and the middle lobe. Like this, you will have a great exposure on the next bronchovascular element of the segment 3. Here is a video to show you the dexterity of the robotic platform for the lymph node. And segmentectomy, it's important to check the lymph node, intrapulmonary lymph node, station 11 and 12. And I think it's a great value of this robotic platform. I think for the mediastina, for station 7, 8, 9, its VATS and RATs are very good. But for the station 11 and 12, there is a real benefit of the robotic platform. Here there is two arterial branch for the middle lobe. We know that thanks to the 3D planning, so no surprise, no doubt. And now we will open the fissure. Sometimes the exposure is better from the front, sometimes it's better from the back. So my stapler is coming depending from the front or from the back, depending what is the best to be safe. Once you open the fissure, you can have the 3D planning inside the console. It's tied with TilePro. It's possible to have the 3D planning. We continue the lymph node dissection, station 12, 11, and 12. Here is the first pulmonary arterial branch. So from the main trunk, it's a common trunk from A1 and A3. Here is only A3, the first one. We control this first arterial branch, and we use a vessel loop to have a distance with A1 and V1. And now with the robotic stapler from the back, better exposure, we control the first one. And now the second one. One more time, no doubt, we know that, so there is no surprise. Is it A2, A3? You know it's A3. So now you're much more safer, and you cut the second one. Once you finish the two arteries and the vein, it's time for the bronchus. And here is the adjacent lymph node. And David will explain you the concept of adjacent lymph node later. This one is it's station 12. It's close to the B2. And this lymph node should be sent on frozen section to be sure there is no involvement. So we remove this lymph node and ask our pathologist colleague. Now it's the section of the bronchus, B2. And we use a robotic stapler, and we do inflation deflation test to check there is no issue, even with 3D planning. Like this, there is no problem. And now you see I'm performing the 2 and 4R, the Barretti zone, because I'm waiting for my pathologist on frozen section. So I continue the mediastinal dissection during the time necessary for my pathologist colleague, and I do a radical dissection en bloc, even for small lesion. The message is to do always the same kind of radical lymph node. It's not depending the case, it's always the same. Like this, you will be able to identify some occult N+ disease. And one more time, David will explain you the high rate of occult disease, even for small lesions. So I think it's very important, and this is the value of this as a thoracic surgeon. We are oncological surgeon, and radical lymph node is important. Here you can see the shape of the S3. We have the shape of the S3 with the 3D planning, and we inject ICG through the vein of the patient, and we will have exactly the same shape design of the S3 segment. So it's very comfortable for the surgeon to say, okay, it seems to be the good surgery. I think I cut the good vessel because I have exactly the same shape with the ICG. Then a second surgery begin. It's the intersegmental plane, very difficult part of the surgery. So we use clamp to make it thinner, and we check if we have always the bronchovascular element on the specimen. You remember to avoid the wedgectomy. So it's important to have the bronchovascular stump. I like to use a pleural sealant in order to decrease the rate, the risk of prolonged air leaks. And we use a very small and very small chest tube, 6 French. In general, we are able to remove the chest tube the same day or at least the next day of the surgery. We use the reinflation, and you can see S1 and S2 very well reinflate. David, can you explain the advantage of
Absolutely, thanks, Elias. Before we move on, there was one question that we might want to address at this point. It's from
of course.
It says, do the segment borders matter after dividing the artery, vein, and bronchus and removing the lymph nodes for less than 2 centimeter tumors? I mean, I would say yes, they do. And that's the beauty of using indocyanine green, is that you know exactly where the perfused versus the non-perfused borders of that segment are.
Yeah, I agree.
We agree. Good. So moving on, I think Elias referred to this, but I think another huge advantage for me, at least, is the identification of aberrant anatomy. This patient had left upper lobe carcinoid, but he also had an abnormal mediastinal takeoff of the lingular artery that wasn't that obvious on the axial imaging, but when we do a 3D reconstruction of this, you can definitely see where that lingular artery is. And so knowing this in advance going into the operating room really, I think, facilitates the performance of the procedure in a safe manner and an accurate manner. So we're not dividing the wrong vein or artery. This is that aberrant branch that you can see that we're dividing. And then in a similar manner, just like Elias showed, using the ICG is, I find, really helpful. So the next guideline, we can go on to the next slide there, Elias. The next guideline, guideline 10, refers to how do you deal with the segmental veins. Now, the guideline states that it's best done dissecting the veins out into the parenchyma, not at the hilum. And the reason for this is that the venous anatomy is a little bit different to the bronchopulmonary units than the arterial and the bronchus. So there's a single artery typically, and there's a single bronchus to the segment, and they go centrally. But the veins are different. There's usually a central vein, but then there's also these intersegmental veins. The problem with intersegmental veins is if you cut those off at their origin, you not only take out the venous drainage to the segment that you're taking out, but you also take out the venous drainage to other adjacent segments. In addition, the venous anatomy is significantly more variable than is the arterial, the bronchial anatomy. So oftentimes it makes sense to divide the bronchus and the artery separately, but unless you're absolutely certain that you're taking only the vein to that one segment, sometimes it's better to take the veins en masse when you do your parenchymal resection. So this is a patient that I recently operated on that shows the problem doing this, right? She had 2 lesions. She had an apical lesion there, and she had another separate cancer, different cell type, in the basilar segments. And our plan was to do a segment 9 + 10 + 7. So we're taking out the medial and the posterior and lateral segments. So we're dissecting the veins here way out into the lung parenchyma before we can divide them. And even still, I think I probably made a mistake in this patient and probably ended up dividing some of those intersegmental veins. So this is the vein that I think is going to segment 9, 10. We divided that. We're dividing the arterial supply now and the fissure and now the bronchus. And then we're going to give our shot of ICG, which is going to tell us nicely where the perfused versus non-perfused segments are. And then once we do this, then now we can start dividing the parenchyma. I'm just freeing up that segmental vein to the anterior segment, the V8 vein, trying to make sure that I preserve that. I have to preserve that as well as the V6, which is behind it. But then we start, taking the parenchyma, which is fairly straightforward to do. But the problem here is, I think, twofold. First of all, I think I took some of the intersegmental veins in doing so, but also you'll notice here on this V8 that because I've skeletonized it so much, it looks like there's almost a little kink there. So this patient did great post-operatively for the first 24 hours. You'll see her x-ray now in a second. But then she started developing these lower lobe infiltrates, and they progressed. So we ended up getting a CT scan. I wanted to make sure there was flow at least, and there was flow. But right there, you see probably a little kink in that vein, and you can see this sort of consolidation of that lung. The airways are open. The superior pulmonary, the superior segmental vein was open as well. She ended up doing fine. We just watched it, but it's something to watch out for. The other thing is, the other issues that you can have with vascular division is when you do your parenchymal resection, especially in complex, I'll use the word complex segmentectomies because 9 + 10 segmentectomies for me are complex. It can be easy to impinge on surrounding vessels. This is a patient who had hopefully this will play. There you go. She had a lesion in her lateral segment, so we ended up doing we were planning on doing a 9 + 10 segmentectomy. We're dividing the veins, we're dividing the bronchus now, and just like the last case, we used ICG to define where the cut plane was going to be. So we did all this, and usually what I find helpful in these situations is after you've done this, give another shot of ICG, because it'll tell you whether what's left still has good blood supply. In this case, this patient did not have good supply to the remaining anterior segment there. And so we ended up having to perform, and I probably kinked off a vessel somewhere in that parenchymal division. So we ended up having to perform a basilar segmentectomy, just leaving her with her superior segment. And then the one other area where I've gotten into, again, this is a basilar 9-10 segmentectomy. That's the 9 + 10 artery. We're coming across it. I didn't mobilize it enough, and I didn't rotate the stapler to the right where I should have, because you'll see what happens here. But in stapling this off, I'm going to narrow the remaining vessel to that anterior segment. You can see it right there. So this patient unfortunately had to have a basilar segmentectomy as well. Could have used a clip. I could have tied it off. I could have dissected the vessel. So just something to keep in mind of when performing these resections.
Thank you so much for this very honest and video, because we all have a complication and you give such a long list of good advice. And I like the idea to use ICG at the end of your surgery to be sure the remaining segments are very well vascularized. The next guideline is about the intersegmental plane, and we know that we need to ensure margin. So the recommendation are at least the tumor diameter, but it's not very easy. And you need to ask your pathologist, if you do a frozen section, the distance, not only if it's free margin or not, you need to know the distance. But there is some problem with that. We do distance with inflated lung or deflating lung. So it's not very easy. And also with or without the stapling line. I don't want to have this kind of question with my pathologist. So I think there is a good answer for that, is to do a preoperative assessment of the margin on a good inflating lung. It's with the 3D planning. And this is the concept of personalized surgery, because you will confirm the exact title of your surgery thanks to the 3D planning. On the left part of my screen, we have a CT scan with a lesion on the right lower lobe here on the S10 segment. It's clearly inside the S10, but when you ask for 2 centimeters of lateral margin, you see it's crossing the intersegmental plane. So you need to remove station 9 and 10, and not only S10, if you want to ensure good lateral margin with no doubt. Same on the right part of my screen, you have a lesion, pink part of the small pink, and you can see it's inside the S1. But when you ask again 2 centimeters of lateral margin, is crossing the intersegmental plane. So I think a segment 1 and 2 is more interesting to ensure good lateral margin. And now we decide to cut the parenchyma following the intersegmental plane, but it's not easy. It's not like this. You don't have, you will not face some fissure or some color inside the lung. So it's one more time important to ask for innovation, and ICG is very valuable. And there is a lot of data in the literature about the value of ICG. I like this video I performed a few years ago about the value of ICG because first, if you decide preoperatively your resection thanks to the 3D planning, you have to follow the good surgery in the OR. So if you decide to do S1+2 to ensure good lateral margin, you need to be sure where is the intersegmental plane. So thanks the ICG, you will be able to have a good lateral margin and no local recurrence. And also, if you cut the parenchyma on devascularized tissue, you will have probably some problems, some issue with the healing of the parenchyma and maybe some air leak. So it's important to cut on a very well vascularized tissue. Here is the right upper lobe, S2, S3. We do inflation deflation test. It seems to be here, the intersegmental plane. But when we inject ICG, you will see finally the intersegmental plane is not exactly at the same place. And fortunately, we check with ICG, and like this, we will put the jaw of the stapler much more on the right to ensure lateral margin and also better healing because stapler on a very well vascularized tissue. Intersegmental plane is difficult to have a good exposure, and I think this is a very good element of the robotic platform because you have a multi-port access and you can always have a good exposure, putting the camera, the scope on different trocar if necessary. Like this, you also never touch the remaining lung and you avoid air leakage, and you be sure about the venous drainage of the remaining segment, as explained David. When you cut the parenchyma, you want to respect the remaining segment and mostly the vein. And also, I explained you many times from the beginning of this webinar, the importance of the bronchovascular stump on the specimen, and to be sure you need to have a good exposure. It's an example here. Sometimes the jaw of the stapler is coming from the front or sometimes from the back, depending what you need. About the margin, the guidelines say that in case of positive margin during the frozen section, you need to extend the resection to the adjacent segment or to the lobe. It's not always easy to remove one more segment after cutting the parenchyma. Lobectomy is a good surgery. So if you have a positive margin, I think the best way to cure the lung cancer is to go for lobectomy. And if you finally have an uncertain margin at the final pathologic report, the guideline explain to discuss the case at the tumor board, and clearly lobectomy may be considered whenever it's possible and reasonable. But to avoid this kind of discussion with your pathologist or with your oncologist colleague during the tumor board, one more time, I really recommend you to do a preoperative assessment of the lateral margin. And I think 3D planning and ICG is the best way to ensure good lateral margin. And this paper is very interesting to read.
Okay, so moving
about
on.
Lymph node, David, please.
The lymph nodes, yes. Well, you saw a beautiful lymph node dissection by Elias there in that S3 segmentectomy that he did. So guidelines 11 and 12 state that all lymph nodes draining the target segment should be resected as in addition to a systemic or lobe-specific lymph node dissection. So why do we do this? Well, because there's probably around a 15 to 17% incidence of occult N1 or N2 disease for early stage lung cancer, and guidelines recommend this. The ISLAC guidelines recommend 3 mediastinal and 3 N1 nodes. Commission on Cancer here in the United States recommend 3 N2 stations, but only one single N1 station for curative resection for lung cancer. Why? Why do they do this? Well, we know from the lung cancer literature from over 2 decades ago that there's a survival benefit between having a lymph node dissection done and not. And this is even before the adjuvant chemotherapy days. The lowest curve are patients who had some form of a low curative resection for lung cancer who did not have any lymph nodes resected. And then the more lymph nodes that are taken out, the better the survival is. This is true also for segmentectomy. This is an interesting study. It's from SEER. And they looked at, is there a survival difference between lobectomy and segmentectomy? Well, on the face of it, yes, there was, right? But if you look deeper, in this group of patients, only 26% of patients who had segmentectomy had no lymph node dissection whatsoever. That was only the case in 3% of lobectomy. So actually, when you split the survival down by according to whether or not they had lymph nodes resected and the extent of lymph nodes resected, there's no difference in survival. And this is for overall survival and lung cancer specific survival. And then using the same database, but from a slightly later cohort, Sayem Murray also showed, just like the earlier lung cancer studies showed, that for patients who had undergone segmentectomy, there is a difference. If you don't have lymph nodes resected, which is the lower blue bar, you do significantly worse than if you have lymph nodes resected. Therefore, it's important to perform a good quality lymph node dissection. And I do this very simply. You can skip through these really quickly. I like to start off at the bottom and go up the back of the lung, around the hilum. I take these paratracheal nodes out, and then I come around to the front. On the left side, it's exactly the same. I just go in the opposite direction. Again, inferior pulmonary ligaments, subcarinals, the 5s and 6s, and then the 10s. But just have a system and stick to it. It's very important, I think. Right. So they also recommend, guidelines 13-14, that you do the frozen section. As Elias showed, it's all about the lymph node dissection. You got to get those lymph nodes out from the adjacent bronchus. So the bronchus that's actually attached to the target segment, right? Those adjacent lymph nodes are very important. Typically, those are station 12 lymph nodes. And we send them off for frozen section. Why? Because if an adjacent lymph node has tumor, there's about a 40% chance of there also being tumor in other segments that are adjacent to that segment that you're taking out, okay? And so if we were to only take out that lymph node, that segment, we would run the risk quite often of leaving potentially tumor behind in other isolated lymph nodes at the other segments. And so that's why these guidelines recommend that you perform, first of all, the frozen section on the station 12 lymph node, the adjacent lymph node. And if that's positive, that you proceed at the time of surgery to a lobectomy. Okay. If that adjacent lymph node is negative, then it's safe to proceed with the segmentectomy. Now, what happens, which sometimes happens, if you do your segmentectomy, and then 7 days later, your pathologist tells you on the pathology report that one of those lymph nodes, either 11 or 12 or even a paratracheal node, is positive. What do? Well, typically the advice is not to go back to do a completion lobectomy. And this is the reason why. First of all, there's retrospective data from the Maury's group where they looked at this. They had 275 patients, all underwent segmentectomy. They had a 6% incidence of positive nodes that were found. These were occult nodes. These were only found after the case had been done. In 10 of these 15 patients, they went back at a later date and did a completion lobectomy. None of those patients were found to have residual cancer in the lymph nodes, and 2 of these patients recurred distally. In the segmentectomy group, there were 5 patients who just had segmentectomy, did not have completion lobectomy. Well, 2 of those patients also succumbed to distant disease. So the thought is that if you've got nodal disease, that if it's found occult and the surgery is done, it's better that these patients be referred for adjuvant chemotherapy. And this is NCDB data that looked at this situation as well in far greater numbers of patients. And you see that patients who were found to have occult N1 or N2 disease had similar survival, whether or not they had a segmentectomy or whether they had a lobectomy. At this point, it's a systemic disease. These patients need adjuvant chemotherapy. And this is another study using NCDB data. The green and the blue lines are patients who had either lobectomy or segmentectomy and then went on to receive adjuvant chemotherapy. So it works. If you don't receive adjuvant chemotherapy, that impacts your survival. But between segmentectomy and lobectomy, there's no difference between survival for patients who have occult positive nodes. So therefore, the recommendation is not to proceed to completion segmentectomy if this is found on a post-operative pathology report. Elias.
Yeah, thank you very much. Another question about the segment is what do you do in case of STS at the definitive pathology? And one more time, the guideline explain to rediscuss at the tumor board. And one more time, completion lobectomy should be discussed whenever it's possible and reasonable. Why? Because STS is clearly the new sheriff in town. I think it's even more important than the lymph node for the segment. Why? This beautiful paper from MSKCC explained that even for small lesion, so it's very T1 adenocarcinoma, and they compare lobectomy, so black, and sublobar, the red. When you don't have STS, there is no difference. But when you have STS, clearly it's in favor of lobectomy. And when you look deeper only for sublobar resection, it's wedge and segment. When you look deeper, when you don't have STS, so no STS, if you have a good lateral margin, there is no local recurrence. And we already explained that you need at least to offer the tumor diameter. And when you have STS, even if you have good lateral margin, you will face some local recurrence. So clearly, it can explain the high rate of recurrence in the sublobar group. And this paper is interesting because they said that STS is clearly associated with micropapillary and solid subtype. So if you find on the preoperative biopsy some micropapillary or solid subtype, maybe you should ask during the frozen section if there is STS or not, because this paper said that it's possible. It's only 70% of sensibility, but it's possible. And another meta-analysis about segment or sublobar resection for small lesion, and they check for the importance of the STS, and the conclusion is that lobectomy is clearly more effective when you have STS present. So to conclude, the main issue with international segmentectomy is clearly local recurrence. And I think we just explain you all the risk factor, and we have the possibility to control all of this. And in the literature now, it's very well known which factor we have to control: the size, where the lesion is located, where is the localization of the lesion, if there is micropapillary or not, STS or not, good margin or not, and all of this. To conclude, we are today at the landscape of a lot of screening program with a lot of small lesions to operate on. Segmentectomy seems to be a protective factor thanks to the GCOG, and segmentectomy is clearly probably the new standard only if we are able to ensure good oncological rules, meaning margin and all of this. But it's not because you have a small lesion that segmentectomy is always technically or for oncological result feasible. If you have any doubt, it must benefit for the patient, and lobectomy is a very good weapon. The final decision to perform or not a segment, it's only during the surgery, because you need frozen section, and you have to explain your patient it's a segment or a lobe, and you will see. And clearly, all of these challenging procedures are complex, and it's a long learning curve. And I think we need to know how to do with this challenging intervention. And there is a good part of the standardization and the the innovation, because when you use 3D planning and when you ask your colleague like interventional pneumologist for the localization and pathologist, it's much more easier. So I think it should be even mandatory to have all of this package to help you to perform this challenging surgery. And to conclude, it's important to do all of this surgery inside an ERAS program. Thank you very much for this long presentation, and we will be very pleased to answer all of your questions.
Thank you, Elias. We have two questions that haven't been answered yet. First of all, from Oliver Mueller, will there be a recording available online? I think there will be, correct? Clemens?
Yeah, I also like to thank the two of you for your excellent presentation. I sense there's a lot of agreement across the pond on how this patient should be treated. I also should send apologies from Isabel Opic. She had to run for an emergency, so in the end she couldn't participate. Yes, there will be a recording taken, and it will be accessible for the ESTS members via the ESTS website. And for the STS part, I'm sure there also will be a possibility for replaying this video.
Excellent.
Question quickly from Dr. Gomez de Antonio. What would be your decision in case of detecting N1 or N2 disease intra-op, sublobectomy or lobectomy? I would do a lobectomy personally. And do you routinely send 10s and 11s for frozen section in the case of sublobar resection? I typically do. I like to be as certain as I can. Elias, maybe you'd answer from your perspective.
Thanks, David. I do the same. So 11 and 12 routinely send for frozen section. 10, not always, but 11 and 12. And clearly, in case of N1 and N2, I will go for a lob. I think we don't have enough data today to say if we can do even for N plus disease a segment, because you show us very good data about the importance of the chemo, because when you have the adjacent treatment, because when you have N plus disease, it's like a metastasis disease. So the most important is clearly the adjuvant treatment. And I still think lobectomy should be performed in case of N plus disease.
Yeah, I think like you said, we don't have enough data really yet about that. And then last question from Pierre Youssef for you, Elias. Which pleural sealant do you use?
So there is different brand, and in my practice, I use a Progel because it's very simple and easy to apply. There is other company, but it's very simple by minimally invasive approach, and I use Progel in routine for every patient.
We talked a lot about 3D planning, and I think I mentioned in the question and answers that there's a lot of different software options out there. And I won't mention any commercial brands, but there are also freeware versions available. And the one that I used for that mediastinal aberrant mediastinal A4, A5 was something called Slicer 3D, or 3D Slicer, I think they call it. It's completely free to use. It takes a little bit of time. I did put the link in the question and answer, so if anybody's interested in that, it's there.
David, I have a question for you. You showed that you're using an ICG shot after the segmentectomy in order to determine the perfusion. Do you have any certain threshold or any parameters on how to decide whether you're going to do a completion lobectomy or not?
Well, if sometimes there's a little bit of non-perfused area, especially right at the staple line. That's not unusual. I don't worry about that. But if I have a significant amount of a remaining segment, I'll wedge that out because I don't want to leave non-perfused lung there. I worry about infection or problems with it. I think it's simple to do, and if it's not being perfused, it's not going to be functional anyhow. So
I do the same.
You think this might correlate to the functional outcome in the trials that is probably not routinely done?
I think it's possible. I also think it's possible that First of all, I don't think we've got very good measurements of postoperative pulmonary function. Their spirometry, maybe FEV1's not the best metric to use. I don't know. There probably are more sensitive ones. Secondly, I think that, as you could see from certainly my videos, you get a fair amount of architectural distortion, particularly when you're doing some of these really deep segments. And I think that probably compromises pulmonary function postoperative. There are patients that I've operated on where I've done a beautiful operation, the lungs inflated great, and I get a CT scan 6 months later, and the remaining adjacent segment is collapsed. So I think part of it is, just architectural distortion.
Okay, so well then, I'd like to once again, on behalf of the entire educational committee of the ESTS, thank you both for this really excellent presentation and overview. And yeah, thanks for the participants, for the lively discussion afterwards, and wish you all a nice evening today.
Thank you.
Goodbye.
Bye-bye.
Thank you.
All right, thank you.